for decades, treating a migraine was, well, it was kind of like throwing a heavy wrench into a delicate, like highly complex, malfunctioning engine.
Yeah, just completely lacking any kind of finesse.
Exactly. You're just standing there watching the gears spark and sputter, and you just toss this chunk of metal in there. And you're crossing your fingers that it happens to, jam the right gear and stop the malfunction.
Oh, right. Instead of just completely destroying the whole machine in the process.
Exactly. So, welcome to this deep dive. Today, we are opening up a stack of clinical and pharmacological source materials that detail the history, the mechanics, and the sheer limitations of a class of drugs that completely changed that approach.
It really was a massive turning point.
It was. It's a medication that essentially took that clumsy wrench and replaced it with a precision instrument. We're talking about triptans.
And it's such a fascinating topic to unpack.
It really is. So our mission today is to explore exactly how triptans revolutionized migraine care. The fascinating biology of how they actually work inside your brain, the very real risks that come with taking them, and then a truly surprising surgical option for patients when those medications ultimately fail.
Right, because to appreciate just how seismic the shift was when triptans arrived on the scene, you first have to understand that a migraine isn't just it's not just a bad headache.
Right. It's not just from staring at a screen too long.
Exactly. It isn't a tension ache from staring at your phone or having a stressful day at the office. I mean, a migraine is a highly complex, cascading neurological event.
A full body thing almost.
Basically, yeah.
Yeah.
It actively involves your blood vessels, your cranial nerves, and this just massive wash of inflammatory chemicals. Reversing it requires a deep, deep understanding of the specific biology of that cascade.
And before the medical community understood that specific biology, the dark ages of migraine treatment they were incredibly grim.
Oh, absolutely brutal.
Just looking at the historical notes from the 20th century in our sources, patients were desperate. And the treatments they were forced to endure they were incredibly rough.
Yeah, the clinical landscape back then relied heavily on ergotamine derivatives.
Which are what, exactly?
Well, these were compounds that had been utilized since, the 1920s. Things like ergotamine tartrate. And, they did occasionally abort a migraine, but their mechanism of action was just incredibly imprecise.
Kind of like the wrench.
Exactly like the wrench. Ergotamines interacted wildly with a broad, chaotic range of receptors all over the body. We are talking about serotonin receptors, dopamine receptors.
Wow.
Yeah, and adrenergic receptors all just being stimulated at once.
Okay, let's unpack this for a second. If you think about the ergotamines, it was basically a shotgun approach.
That's a perfect way to describe it.
Right, so a doctor fires it off into the patient's system, and it hits everything. It peppers the dopamine receptors, it aggravates the adrenergic receptors, and the hope is just that, a few of those random pellets hit the actual migraine mechanism.
Right, but the collateral damage.
Yeah, the collateral damage to the patient had to be just massive.
Oh, the collateral damage was severe. Because ergotamines hit so many unintended targets simultaneously, they were notoriously poorly tolerated. The most dangerous side effect was widespread systemic vasoconstriction.
Meaning shrinking the blood vessels.
Exactly. But they didn't just constrict the blood vessels in the head where the migraine was happening, they constricted blood vessels all over the patient's body. And overuse carried a very real risk of a condition called ergotism.
Which I read about in the sources, and it sounds absolutely terrifying.
It is severe. Ergotism occurs when the blood vessels in the extremities constrict so tightly and for so long that blood flow is essentially cut off completely.
Wow.
Tissues in the fingers and toes are literally starved of oxygen, which can lead to extreme pain, neuropathy, and in historical or really severe cases, actual gangrene.
Gangrene. Wait, really? From headache medicine?
Unfortunately, yes. Migraine patients were essentially trading this neurological firestorm for a medication that could systemically choke off their circulation.
That is just a brutal trade-off.
Yeah.
So how did we finally put the shotgun away? How did we actually get to triptans?
The pivot happened because of clues researchers started uncovering in the 1960s and 70s regarding a specific neurotransmitter, serotonin.
Okay, serotonin, usually associated with mood, right?
Right, but it does so much more. During an active migraine attack, researchers noticed patients had elevated levels of a serotonin byproduct. It's known clinically as 5-HIAA in their urine.
Okay.
But simultaneously, the actual serotonin levels in their blood platelets were plummeting. So this inverse relationship strongly suggested that serotonin wasn't just, a bystander. It was actively driving the cascade of migraine pain.
Okay, so the researchers knew serotonin was the key. But they couldn't just flood the body with random serotonin drugs. Because that leads right back to the shotgun problem, right?
Precisely. You'd just be hitting everything again. And that brings us to 1972. A pharmacologist named Patrick Humphrey and his research team at GlaxoPharmaceuticals, they initiated a highly targeted hunt.
They wanted a specific tool.
Exactly. They weren't looking for a general painkiller. They systematically searched for a novel compound that would selectively activate only a very specific subset of serotonin receptors, specifically the 5-HT1 receptors.
And those are located where?
They're predominantly located right on the cranial blood vessels in the head.
Okay, here's where it gets really interesting. They essentially engineered sumatriptan to be a sniper rifle.
Right.
Instead of blasting every receptor in the body like the ergotamines did, sumatriptan was designed to specifically target the exact local biology of the migraine attack, completely ignoring the dopamine and adrenergic receptors.
And that design really paid off. I mean, after years of systematically refining molecular structures, Humphrey's team arrived at sumatriptan succinate. It demonstrated potent, highly selective activity at the 5-HT1B and 5-HT1D receptors.
So they finally found their sniper.
They did. And when clinical trials finally commenced in the late 1980s, the results were a true paradigm shift in medicine. I mean, patients who had never found relief in their entire lives were suddenly reporting rapid, robust pain freedom.
And the FDA approved sumatriptan in 1992, initially as a subcutaneous injection, which, that just blew the doors off the migraine world.
I completely transformed it overnight.
But I want to dig into the machinery here a bit. Once this molecular sniper enters your bloodstream, how exactly does it stop a migraine in its tracks? Our sources indicate it's actually a three-pronged attack inside the trigeminal system.
It is, yeah. So the first mechanism is cranial vasoconstriction. During a migraine, the blood vessels in your head, particularly the meningeal and dural vessels surrounding the brain, they dilate. They swell up.
Okay.
And that physical expansion is what generates that horrible throbbing, pulsatile pain patients feel with every heartbeat.
Right, the classic pounding headache.
Exactly. So triptans bind directly to the 5-HT1B receptors on the smooth muscle lining those specific blood vessels and force them to constrict, effectively reversing that painful dilation.
Okay, I want to push back on that for a second, though.
Sure.
If migraines cause blood vessels to swell up and throb, isn't simply squeezing those vessels back to their normal size enough to stop the pain? Why do we need the drug to do anything else?
Well, what's fascinating here is that the vasodilation is just a physical symptom of a much deeper neurological fire. Squeezing the blood vessels stops the throbbing, sure, but it doesn't put out the fire causing the vessel to swell in the first place.
Oh, I see.
Yeah, that requires the second mechanism, which is inhibiting the release of neuropeptides.
Yeah.
You have trigeminal nerve fibers wrapped intricately around these cranial blood vessels.
Okay.
And during a migraine, these specific nerves are essentially vomiting out a continuous cascade of highly inflammatory chemicals, specifically proteins known as CGRP and substance P.
Okay, let's make sure we define those. When you say CGRP and substance P, what are they actually doing to the tissue inside the head?
They are powerful vasodilators and pain sensitizers. When the nerve endings dump CGRP and substance P into the surrounding tissue, they create a literal soup of neurogenic inflammation.
A soup of inflammation. That sounds awful.
It is. They cause the local tissues to become red, swollen, and hypersensitive to pain. So the triptan combats this by binding to 5-HT1D receptors on the presynaptic terminals of those trigeminal nerves. It acts like a molecular lock, instantly shutting off the release of those inflammatory proteins.
So it doesn't just squeeze the swollen vessel back down, it actually turns off the chemical faucet that was causing the swelling in the first place.
Exactly. And then there's the third mechanism, which operates much deeper, entirely within the brainstem.
Okay.
Specifically in an area called the trigeminal nucleus caudalis, or TNC. This is the central relay station where pain signals from the cranial blood vessels are received before being sent up to the brain's cortex to be registered as conscious pain.
So it's like the switchboard.
Right. And certain triptans that can cross the blood-brain barrier, they enter this relay station and bind to receptors there, essentially blocking the pain signals from ever reaching the higher brain.
So it's literally cutting the phone line before the emergency call can reach the receiver.
That's a great analogy.
You shrink the blood vessels, you
Yeah.
stop the inflammatory chemical bath, and you block the pain transmission in the brainstem. That's the three prongs. But getting this drug into the system seems to be a major hurdle.
It really is.
The sources emphasize that these are abortive treatments, meaning you take them to stop an attack that has already started, but the way you take them dramatically changes the outcome.
Yeah. Oh, completely. The formulation is critical, and it all comes down to a concept called bioavailability.
Bioavailability.
Right. In simple terms, bioavailability is the percentage of the actual drug that successfully survives the journey through your body to reach your active bloodstream. Subcutaneous injections bypass the digestive system entirely.
So they go straight in.
Exactly. They deliver about 97% bioavailability, so they act fast and typically bring meaningful relief in just 10 to 20 minutes. In clinical trials, the injection provides about 55 to 70% of patients with total pain freedom at the 2-hour mark.
Which is an incredible statistic for a neurological disease.
Sure.
But, I mean, most people aren't carrying around syringes, right? They use oral tablets.
Most do, yes.
And the success rate for the pills is much lower. It drops to around 30 to 50% pain freedom at 2 hours. Why is there such a massive drop-off just from swallowing a pill?
This highlights one of the most insidious biological tricks of a migraine attack. It triggers something called gastric stasis.
Gastritastasis.
Yeah. During a severe migraine, the body's sympathetic nervous system activates a systemic fight-or-flight response. The brain perceives a massive crisis, so it diverts energy away from non-essential functions. And primarily that means digestion. The stomach literally, physically stops moving. It stops emptying into the intestines. Oh, wow. So the patient swallows this highly advanced molecular sniper, but because of the gastric stasis, the pill just sits there in a paralyzed stomach acid pool, completely unable to be absorbed into the bloodstream where it's needed.
Exactly. This is why nasal sprays and orally disintegrating tablets were developed for patients who experience severe nausea or rapid gastric shutdown.
That makes total sense.
But regardless of the formulation, the clinical guidelines stress one absolute rule. Timing is everything. A triptan must be taken early in the attack. If a patient waits too long, the migraine progresses into a state called central sensitization.
Okay, I read about this in the source material, and it is a wild symptom. Central sensitization is when the pain signaling gets permanently locked into the brainstem for the duration of the attack, right?
Yes.
And clinically, doctors look for a symptom called cutaneous allodynia. This is when things that absolutely should not hurt suddenly cause agonizing pain. The skin itself becomes hypersensitive.
Patients report that just resting their head on a soft pillow or brushing their hair, or even just the weight of their glasses on their nose, it physically burns or aches.
And once cutaneous allodynia is present, it is a giant clinical red flag. It means central sensitization has fully established itself. At this late stage, oral triptans lose a massive amount of their efficacy.
Because it's just too late.
Right. The pain cascade has essentially outrun the drug's ability to intercept it.
So what does this all mean? If triptans are this incredibly tailored three-pronged weapon against migraines, why aren't they a universal cure? The sources are very clear about the limitations and the risks because they are significant.
They absolutely are.
First off, there is a ceiling to their effectiveness. Roughly 25 to 35% of migraine patients get absolute no relief from their very first triptan. They are true non-responders.
Right.
And even when the drug is successful, 15 to 40% of the time, the migraine comes roaring back within 24 hours, which is known as headache recurrence.
And beyond the efficacy limits, we have to look at the side effect profile. Most notably, the phenomenon known as triptan sensations.
Triptan sensation.
Yeah, between 10 and 40% of patients experience these, particularly those using the rapid onset injections. They frequently describe a sudden tightness, intense pressure, or just a really heavy weight in the chest, the neck, or the jaw.
Likes.
Sometimes it presents as profound flushing or a severe tingling sensation radiating through the face and extremities.
I can only imagine how terrifying that must be if a doctor fails to warn you. You take a pill for a migraine, and 20 minutes later, your chest feels crushed under a heavy weight and your jaw locks up.
Right.
The immediate thought is going to be that you're having a massive heart attack.
Oh, it induces severe anxiety in patients. Now, clinically, these specific sensations are usually benign. They are generally believed to be caused by the drug contracting smooth muscle in the esophagus or skeletal muscle rather than an actual cardiac event.
Okay, that's somewhat reassuring.
However, They do shine a glaring spotlight on the very real cardiovascular risks inherent to the drug's design. Because triptans fundamentally work by causing vasoconstriction, they are strictly contraindicated for any patient with ischemic heart disease.
Let's define ischemic heart disease for clarity, just so everyone's on the same page.
Sure. Cardiac ischemia occurs when the arteries supplying the heart become narrowed or blocked, literally starving the heart muscle of the oxygen it needs to pump.
Got it.
If a patient already has compromised, narrowed blood vessels or a weakened heart, introducing a systemic drug that forcibly constricts their blood vessels further is incredibly dangerous. It can trigger an actual heart attack or stroke.
Wow.
Therefore, they cannot be prescribed to anyone with a history of stroke, uncontrolled hypertension, or peripheral vascular disease.
So a whole subset of the population is completely locked out of this treatment.
Unfortunately, yes.
But for the millions of people who can safely take them, the sources outline another massive trap just waiting to spring. It's an agonizing condition called medication overuse headache, or MOH. If a patient takes a triptan for 10 or more days out of a single month, the drug itself can actually cause them to develop chronic, daily rebound headaches.
And this represents one of the most frustrating challenges in headache medicine. When the brain is frequently exposed to triptans, it begins to neurologically adapt.
It changes itself.
Exactly. It alters its own pain modulation pathways and changes the expression of its serotonin receptors. The acute migraine attack might respond to the pill, but the brain's baseline threshold for pain drops.
Oh, man.
So the migraines start recurring faster and faster, dragging the patient into a relentless, near-daily cycle of pain. And the only medical treatment for MOH is the total abrupt withdrawal of the overused medication, which is just an agonizing process for the patient to endure.
It reminds me of someone constantly hitting the snooze button on an alarm clock. You hit the button to stop the horrible noise, but if you slam it too many times, the internal mechanics of the clock physically break and the alarm just starts ringing constantly, 24/7.
That's a really good way to visualize it.
You're desperately trying to stop the noise, but your fix has literally become the root cause of the noise.
Right. And this dynamic creates a deeply painful psychological paradox for the patient. Consider the conflicting rules we've just discussed.
Okay.
On one hand, the patient is told they must take the triptan early in the attack at the very first sign of pain to prevent gastric stasis and central sensitization.
Right, the absolute rule. Strike early before the allodynia sets in.
But on the other hand, the patient also knows that if they take the drug too many times a month, they will trigger a medication overuse headache and ruin their baseline health.
It's a catch-22.
Exactly. So when they feel a shadow of a headache starting, they hesitate. They stare at the pill bottle and think, is this going to be a severe one? Should I burn one of my allowed monthly days for this, or should I wait to see if it goes away on its own? They are terrified of the treatment itself, which leads to delayed intervention. By the time they realize it truly is a severe migraine and take the medication, central sensitization has already locked in and the drug completely fails. It is a vicious cycle of prolonged suffering driven entirely by the fear of medication overuse.
That is just a brutal reality to live with. Which brings us to a critical junction in our deep dive. What exactly happens to the patient who has run out of options?
Right.
The patient with a history of cardiac ischemia who cannot risk the vasoconstriction, or the patient who falls into that 25 to 35% of true non-responders and gets zero chemical relief. What happens when optimized pharmacology entirely fails?
Well, our source material reveals a fascinating, entirely structural alternative, and it's not a new generation of pills.
No, it's not.
For a highly specific subset of patients suffering from refractory or treatment-resistant migraines, clinical research, most notably pioneered by a plastic surgeon named Bam Gairan, suggests that peripheral nerve compression plays a massive, overlooked role in generating these attacks.
Here's where it gets really interesting. A plastic surgery approach to a deeply complex neurological disease.
The anatomical logic is actually quite sound. The operating hypothesis is that specific, localized branches of nerves around the head and neck are physically being pinched, tethered, or irritated by surrounding muscle, fascia, or fibrous tissue.
So it's a physical problem.
Exactly. This constant physical friction continuously activates the trigeminal vascular system we discussed earlier. It keeps the system in a state of hyperarousal, drastically lowering the threshold for a full-blown migraine attack to trigger.
It's like stepping on a garden hose.
Yeah.
The water, or in this case, the nerve signaling, it builds up intense physical pressure behind the pinch. until it finally bursts into a massive migraine.
Perfect analogy.
Now, I know the sources identify very specific trigger sites for this physical pinching, right?
They do. Clinical mapping often points to the greater occipital nerve at the back of the head, which weaves through a very thick muscle in the neck. There is the zygomaticotemporal nerve located at the temple, and additionally, the supratrochlear and suborbital nerves, which run right above the eyes around the brow bone.
So if a patient has a nerve being pinched by a muscle above their eye, how does a doctor even prove that's the cause before doing surgery? I mean, you can't just guess.
No, you can't. They utilize a very elegant diagnostic test. During an active attack, doctors will inject a local anesthetic nerve block, or sometimes botulinum toxin, directly into those specific suspected trigger sites.
I see.
If temporarily numbing or paralyzing the muscle at that exact physical location immediately terminates the migraine pain, it provides strong diagnostic evidence that that specific tethered nerve is the anatomical source of the problem.
And if they positively identify the site with the nerve block, they move to the permanent fix. Nerve decompression surgery.
Right.
The surgeon physically goes in and removes, cuts away, or modifies the muscle, the fascia, or the connective tissue that is mechanically pressing on the nerve. They literally untangle the wire. They free up the nerve.
They do.
And a pivotal 2009 trial highlighted in the sources showed significant clinical improvements for these patients. Some saw a 50% reduction in their migraine burden, and a smaller subset actually had their migraines completely disappear.
This raises an important point regarding expectations, however. It is vital to understand that this surgical approach is not a universal cure for the general migraine population, and it remains a topic of active debate among neurologists.
It's not a silver bullet.
Definitely not. It requires incredibly strict diagnostic criteria, clearly identifiable physical trigger sites, and a thorough multidisciplinary evaluation. A patient does not just walk into a clinic and casually request migraine surgery.
Right, it's a last resort intervention. But for the severely disabled patient who has completely failed triptans, who has failed everything else, it offers a profound shift in medical thinking.
It really does.
It shifts the entire battlefront from chemical management trying to artificially manipulate serotonin in blood vessels to a straightforward mechanical resolution. You find the pinched nerve and you physically untangle it.
It serves as a powerful reminder that sometimes an incredibly complex systemic biological cascade can actually be triggered by a very localized physical bottleneck.
So we have covered incredible ground today. We started in the desperate dark ages of the 20th century with the dangerous shotgun blast of ergotamines. We followed Patrick Humphrey's team as they systematically engineered the precision sniper rifle of triptans, reversing dilated vessels, blocking inflammatory chemical baths, and shutting down pain relays deep in the brainstem.
A huge leap forward.
Truly. Then we navigated the treacherous waters of cardiac ischemia risks and the cruel psychological paradox of medication overuse headache. And finally, we looked at the structural, mechanical relief of nerve decompression for the patients left behind by modern pharmacology.
Please remember, this discussion is intended strictly as an educational source material resource. Medical decisions should always be individualized, based on current evidence-based guidelines and clinical judgment, and directed by a physician.
Before we go, I want to leave you with one final thought to mull over. We started this deep dive by comparing migraine treatment to throwing a wrench into a delicate engine. We assumed the engine was a purely chemical neurological machine, but as some of the most severe treatment-resistant migraines can actually be resolved by a surgeon physically cutting away tissue to decompress a facial nerve. Well, what if our modern medical distinction between chemical neurological diseases and mechanical physical pain is actually an illusion? What other invisible chronic pain conditions in the human body are out there, being treated with a lifetime of pills, just waiting for us to find the right nerve to untangle? Thanks for joining us on this deep dive.